Disseminated intravascular coagulation, DIC, and idiopathic thrombocytopenic purpura, ITP. In this uh, study right here, we're going to be talking about perfusion and immunity. These interrelated concepts for this chapter are going to be clotting and gas exchange. First of all, what is DIC? Again, it's disseminated intravascular coagulation. It's basically an issue with the clotting process where we have hypercoagulation of the blood with an overconsumption of clotting factors, and then we have the development of microthrombi. This will lead to extensive abnormal clotting, which uh, will begin to deplete the clotting factors and the platelets that are available. And at the same time, we have extensive bleeding occurring from many sites. This can be just a constant oozing, or it can be a fatal hemorrhage. These clots are then going to begin to block the blood vessels and decrease the blood flow to tissues and major body organs. And when we're blocking blood flow, it causes significant pain because of ischemia. We're not getting blood to the tissues. DIC is always a secondary condition. In other words, it is not a primary disease process that happens in and of itself. It's always secondary to something else. Risk factors for DIC include pregnant clients. These clients may experience complications of preeclampsia, placental abruption, fetal demise, amniotic fluid embolism, aseptic abortion, or HELP syndrome. Other risk factors include infection, especially sepsis. Some cancers or cancer treatments can lead to DIC, and injuries such as significant trauma, maybe with crush injuries and burns. So we need to, first of all, recognize the cues that we're seeing to be able to diagnose DIC. We're going to be observing, looking at these various cues. We're going to look at the client's history and, of course, always do the physical assessment, look at psychosocial assessment, and we also need some lab work. So when we do our physical assessment and our observation, we're going to start seeing some petechiae. It may develop into that purpura. If you look at the picture in this slide, look at the client's legs. That would be purpura, and the arms and the face. We see significant ecchymosis. We can see bleeding, and this bleeding can be internal or external. The client otherwise is going to be very pale, have cool extremities because we're not getting the blood flow. Remember, we have the microthrombi that are now blocking the blood vessels. We will start to see cyanosis of the extremities. The client will have extreme pain with that ischemia. They may also have stroke-like symptoms. There's no telling where all of those microthrombi will be. They'll have dyspnea, tachycardia. Kidneys are going to begin to shut down, so we're going to have oliguria, and we can also have bowel necrosis. This is a very serious situation, and only about 50% of these clients will survive. It can be caused, excuse me, by a variety of things, and it's really important to be familiar with the common causes because that's going to assist us in guiding treatment. Acute DIC will occur rapidly over hours to days, and it's often seen in the pregnant client with complicated pregnancies by eclampsia. Again, with infection, whether it's viral or bacterial. With chronic DIC, this will develop slowly over weeks or months, and cancer will be the most common cause of chronic DIC. Some of the diagnostics that we would do would be a complete blood count, coagulation studies, look at fibrin degradation and fibrin levels, and also a D-dimer. So then we need to prioritize our hypotheses. What is going to be most important for us to take care of in these clients? Well, in order to take care of the DIC, we need to treat the underlying disorder, but we also want to prevent further bleeding and thrombi from forming. Next step in our clinical judgment model is to generate solutions and then take action. As we generate solutions, we know that we need to promote effective tissue perfusion. We need to monitor the client's gas exchange, manage their pain and their fear. They're going to be extremely anxious, and maintain skin integrity. So some of the things we're going to be doing early on in the early phase of DIC is to administer heparin. Heparin at this point will most likely be given intravenously to limit clotting and prevent the rapid consumption of the client's clotting factors. We can give clotting factors later in the progression of the DIC when the hemorrhage is the primary problem at this point. And we'll obtain those clotting factors from fresh frozen plasma, cryoprecipitate, and platelets. These clients may also require the administration of PRBCs, especially if they've lost large volumes of blood through the bleeding process. They will need oxygen, and this may include mechanical ventilation. They'll definitely need some intravenous fluids to help replace any fluids that are lost. Um, and this can include the crystalloids, the colloids, and the protein-containing colloids to help improve that osmotic pressure. We also need to do significant monitoring of these clients. They're very ill. We need to monitor their vital signs, their skin and mucous membrane color, their cognition level, if they're alert and oriented. We also need to monitor their urine output. Again, they're going to become oliguric because of this DIC, and it affects not only the brain and the heart and the lungs, it also affects the kidneys. We can also do some advanced monitoring in these clients, some hemodynamic monitoring, such as doing the central venous pressures or arterial pressures. We can look at the mixed venous oxygen saturation or pulmonary artery monitoring. There are several drugs that we might give for these clients, which would include vasoconstrictors, inotropic agents, or agents that can improve myocardial perfusion, and potentially vasopressors if we begin to lose the blood pressure. And of course, to monitor the urine output well, we need that indwelling catheter where we can measure hourly outputs. And of course, the last part of the clinical judgment model is evaluation. The ultimate goal for the client with DIC is to make sure that the client's body systems are capable of um, dealing with the client's needs of oxygenation, perfusion, immunity, and clotting. So now let's look at the idiopathic, also known as autoimmune thrombocytopenic purpura, or ITP, or ATP. This is an autoimmune condition. Um, it involves a destructive reduction of circulating platelets with a normal platelet production. It is, like I said, considered an autoimmune condition. And what's happening here is the client's immune system is now making antibodies that attack the client's platelets. They're producing platelets, but the antibodies are destroying the client's platelets almost faster than they can be produced. So this significantly disrupts the client's clotting ability. This is a process that is most common in women that are 20 to 50 years of age. Of course, other clients that have autoimmune diseases are also highly affected, but mostly women 20 to 50 years. So let's recognize the cues. When we do our assessment, we're probably going to start seeing large ecchymosis or bruising areas, or purpura, which is that reddish purple fine petechial rash, frequently on the arms, the legs, the upper chest, and the client's neck. We may also see some bleeding of mucous membranes and anemia. We will look at some of the blood work, especially the CBC. This is going to show us the hemoglobin and hematocrit level, which we would anticipate is going to be low because the client is probably bleeding, especially if they have the ecchymosis or purpura, and they will have a low platelet level. We may also look at the antiplatelet antibodies to see if they're present in the client's blood. So what do we do for these clients? Well, if their platelet levels drop below 10,000 millimeters cubed, or they have a life-threatening bleed, we can do a platelet transfusion. It is important to maintain a safe environment and institute bleeding precautions to help reduce the risk of hemorrhage. There are some drugs that can suppress the immune system that would help prevent the destruction of these platelets, such as corticosteroids. We may also give some immunoglobulins, but there's several other immunosuppressants available. And remember, when we give immunosuppressants, one of the main complications, these clients are now at high risk for infection. There's also surgical interventions. If the client does not respond to drug therapy, we may consider doing a splenectomy where we remove that spleen. And since the spleen is also involved in the immune process, then these clients are going to be at an increased risk for infection. They will be highly encouraged to receive vaccinations to prevent disease processes. So let's look at a case study with a 59-year-old 3-day postoperative client. This will help us link the concepts and exemplars that we've been looking at. So we have a nurse caring for a client who's 3 days postoperative after a colon resection. The nurse has delegated to the unlicensed assistive personnel to take morning vital signs. At 8 a.m., the UAP reports that the client's oral temp is 101.6. What is the priority action? Well, when it is reported that the temperature is elevated, the nurse needs to go do a full assessment. We need to determine what might be going on with this client. For example, do they have too many layers on? Or are they potentially developing an infection, which means we need to be looking at the wound, looking at the exudate, What does that drainage look like? And reviewing the client's lab work. What are their white blood cell levels? Different ways we can reduce the temperature, just FYI, if that is necessary, is to remove layers. Many times I've taken care of a client who's had an elevated temperature, and you get to looking and they've got 10 blankets on. Well, no wonder you're so warm. Let's take some of these off and see if that helps with your temperature. We can also decrease the room temperature, put cool cloths or cool packs to the forehead, the neck, the axilla, and or the groin. These are going to be areas where there are larger blood vessels or more blood vessels and will help cool the client down a little bit faster. We could also place a fan on the client and potentially administer some antipyretics. Now, understand this client has had a colon resection. Depending on where that anastomosis site is, in other words, where the colon was cut and sewn back together, if it's very low, we cannot administer suppositories. But if the colon resection was up higher, suppositories may be the route of choice. If the client is able to take oral uh, medications, we might do a liquid or a pill, but just consider where that anastomosis site is. So upon assessment, the nurse will note that the client is flushed and slightly diaphoretic. The client appears lethargic but responds to simple questions. Other vital signs reported are a blood pressure of 90/40, heart rate of 134, respiratory rate of 26, and deep, and the temperature has increased to 102.8. Lungs are clear to auscultation through all lung fields. The client's abdominal wound does have a dressing that is moist with a moderate amount of purulent drainage. The peripherally inserted catheter or PICC line is intact. How do we interpret this data? Well, the development of infection should be considered based on the client's operative history and vital signs and the purulent exudate. The client is also tachycardic, has increased respiratory rate. These are all signs of potential infection. And now we also have hypotension, and the client is lethargic but does respond to simple questions. So we're beginning to have a change in the level of consciousness. All of this can be indicative that something more serious is beginning to develop. 20 minutes later, the nurse calls the healthcare provider to report the abnormal findings. I'm kind of wondering why the nurse waited 20 minutes to phone, but the provider orders are as follows: acetaminophen 650 milligrams PO PRN Q6 hours for a temp above 101, blood cultures times 2, one peripheral and the other from the PICC line. Collect wound cultures for culture insensitivity of the abdominal wound drainage, and vancomycin 750 milligrams IV piggybacked over 1 hour. Now we need to rank the order in which the nurse should complete these interventions. As we look at this client, it's very possible this client is developing sepsis. Not only do they have the infection, but now they've gone septic. So according to the Surviving Sepsis campaign of 2019, we have to do an hour one bundle for sepsis. So we're going to obtain all of our cultures first. So that means 2 or 3 could be done first. We need to get the blood, wound, urine, sputum, cultures, etc. Then we should administer antibiotics, and all of this should be done within 1 hour as we begin to manage sepsis. And then we can treat the elevated temperature. Over the next hour, the client continues to decline with a decreased level of consciousness and a temperature of 103.8. Blood pressure is now 80/40. Heart rate is 134. Respiratory rate is 34. The nurse calls the provider to report these findings and obtains orders for the client to be transferred to the intensive care unit. When preparing for this transfer, the nurse notes that the oxygen saturation is 87% on room air. So what is the priority action? When we're looking at priorities, it's very important to ask yourself this question. And priority would be, what is the highest priority? What is the first action? What is the best action? What is most important, etc. You ask yourself, if I do not do this thing first, something really bad could happen to my client. So your choices are: draw an arterial blood gas sample, apply oxygen at 2 to 3 liters per nasal cannula, administer acetaminophen 650 milligrams by mouth, place the client on a cardiac telemetry monitor. Well, we always look at our ABCs when we're looking at priority. If that is appropriate, that's what we need to take care of first. Then we would look at our change in level of consciousness and or safety next. So at this point, we do have an unstable client. Priority action is going to be that oxygenation status. We need to get that oxygen on the client. They have a rapid respiratory rate, a low SaO2. We have to get oxygen going and then reassess within a few minutes prior to transferring the client to ICU. Once the client's stable, we're definitely going to put some telemetry on them, and we probably should do that prior to transport. This client is very ill. The nurse can also request an ABG sample to be collected and sent to lab by ICU based on the client's presentation prior to transferring them to the ICU. The temperature is going to be the last thing we will address. But, anytime during this situation, this client again is very ill, the nurse can choose to call rapid response team to help stabilize the client, even though we already have that order to transfer to ICU. Again, this client is very ill. Our blood pressure is dropping. We have the elevated temperature. We have the high heart rate. We have the high respiratory rate. This client is probably going to be given IV fluids. We're going to put them on vasopressors, potentially administering some blood products. In addition to oxygen, potentially putting them on mechanical ventilation. So within 30 minutes of the client's transfer to the ICU, the client's condition continues to deteriorate. The SaO2 continues to decrease, respiratory rate is 36, and the ICU nurse notes that there is blood oozing around the PICC line catheter site. An indwelling urinary catheter is inserted, and the urine output is 25 mL with dark amber urine. How do we interpret these assessments? findings. Again, this client is most likely septic. Main manifestations that we're looking at is that low oxygen saturation, that rapid respiratory rate, decreased urine output, and the changes in the level of cognition. And we do know that low oxygenation levels can also cause that change in cognition. We have abnormal vital signs. Surgical wound is most likely infected. We now have blood oozing around that pit catheter site. This client is likely developing DIC.